Before I move forward with our conversation, I want to give a brief introduction about you. So allow me a minute. Uh, I think people merit to know about your background. Dr. Ajaikumar is the executive chairperson of Healthcare Global Enterprises, the company that we better know as HCG. He was in the US and he came back to India to set up HCG. And he says he did that to realize his vision for making advanced cancer care accessible to all. Now, running a healthcare institution not only requires medical knowledge, but also requires certain kind of a entrepreneurial acumen to manage a sustainable venture. Because a lot of us have a lot of a vision and wish list, but we are not able to manage in a manner that is sustainable for a longer period of time. And he has proven both his medical knowledge and also that he has the business acumen. Now, apart from various accolades, he is also a recipient of the prestigious BC Roy Award. He did his MBBS from St. John's College in Bangalore, followed by a residency in radiotherapy at MD Anderson Hospital and Tumor Institute. And then he also did a residency in oncology from University of Virginia Hospital. Now, what little bit I studied about him online, the two things I figured out what he personally enjoys doing is, one, he's a voracious reader, and second is he enjoys running. So am I correct, Dr. Ajaikumar?
Yeah, true.
Absolutely. It's such a pleasure, and thank you so much for taking our time to be with us on this panel.
Thank you very much for having me. Thank you.
Dr. Ajaikumar, my first question to you is that you took up oncology as a specialization way back in the 70s. What I want to know is what prompted you to choose oncology over other specializations?
See, one of the things for me all along, I've always fought for the underdog, even in my medical college, otherwise. And, at that time in 1970s, there were other non-medical issues. We looked at zamindars taking over farms and all. It always made me look at people who were deprived of certain things. And while I went through the medical college, understanding the normal things in medicine, usual things, cardiology, nephrology, a lot of things were attractive. I always wanted to be cardiologist. But when I saw some patients in my final year of medical college in Bangalore, some of the impressions I carried when I went to University of Virginia had a great impact, saying, what is this about cancer? Because in medical college, you don't study that much about cancer. Cancer at that time was considered pretty much gone, terminal patients, nothing can be done. We all saw patients in advanced cases. Out of curiosity, we used to study them knowing that there is no hope. So I took upon it as a challenge because when I saw people with pain, even in US, Virginia, and people I asked my professor once, why is it we are not able to come up with any answers to these? He said, cancer is such an enigma. That word really impressed me. It's an enigma. There's something we can really do. It's like a mystery. Let us do something. So it was more challenging to me to unravel that mystery. That is when I decided, let me go to MD Anderson. And the way I saw MD Anderson was a game changer for me because I truly believed if cancer is treated the proper way, right, first time, we don't need all this, so-called palliative care, so-called, hospice care, so-called using terminologies like, terminal and all. So with that kind of passion, I started looking cancer into the depth. And over the years, what I learned is whatever I had envisioned at that time, whatever I thought cancer accessible, treat it right time first, all of that has become a reality with HCG. That is what I can say very clearly.
Got it. Now, Dr. Ajaikumar, you were in the US. You were well established in your profession there. Your family was there with you. Your children were born there. What prompted you to move back to India?
See, what prompted me was all along when I saw in MD Anderson what I did. I had a great opportunity to stay in MD Anderson in charge of a lung program. By now, I would have become one of the authorities on lung cancer staying there. But I decided I want to learn the ropes of how to do a cancer center. Because I always thought I should go back and do something in India. But what really cemented that, after starting a center outside of Chicago, I became well known. 100-mile radius, people started coming out to get partners. But I put one condition: I want to be away for 3 months a year in India. So I started traveling across. And one of the things is I saw cobalt therapy still being done in India. We are a poor country, we can't afford linear accelerator. Then I saw people waiting for hours together in the Madhya Pradesh government hospital. I remember seeing for 12 hours one kid was waiting with a big sarcoma of the abdomen. And this left a huge impression on me. Look, I have to come back and do something. And fortunately, whatever I started, I somehow was able to convince the family. Obviously, being in US, affluent society, doctor means, affluence, lot of comfort. It is very difficult. A lot of people tell me, to leave US and come back is difficult, particularly when the children also grow up, the children prefer US. In my case, somehow maybe the way I had impacted my passion on my children, and all my 4 kids have moved back to India. Even the one who married an American moved back and said, we will be with you. In fact, Anjali works with me. She's on our board. So it all depends on, family. We say it's how we bring up. I always made them come to India every year, study. And I have a lot of hospital NGOs. They also work, taught in the school as little kids. So that passion, once you create, India is very attractive for a lot of even people who are born there. All my children were born there. And I also had a green card for 40 years. I never became a US citizen, but I even gave up my green card in 2015. I said, I don't need it anymore. So I know my wife and kids are, of course, US citizens. But for me, once I make up my mind, I am like a focus factory approach. People tell me, why are you in oncology? Why don't you go to others? As you know, other hospitals started with cardiology, they become everything. I never did that. We said we are oncology focused, be oncology. So ours 85% is 90% oncology. So I am like a focus factory approach. So I decided, come to India, work in oncology, see how we can change the way people approach oncology treatment. And that was my vision, to change their perception. And what people thought they cannot happen, like linear accelerator, we can bring. Doesn't matter rich or poor, we can. Because cancer knows only one, right treatment. Cancer doesn't know, this guy is rich, so let him have the high technology. This guy is poor, it's okay, cobalt, I will still give. No, cancer doesn't know that. Cancer knows only one way. Cancer is relentless and we have to be relentless. That's all.
So you brought up a very important aspect about the cancer does not differentiate between the rich or the poor. Now, I remember, a few decades ago, there used to be a scenario where if somebody had cancer and the person belonged to an affluent family, and we've seen a lot of celebrity cancer cases brought to light, where they would travel to the US specifically to get the best cancer treatment. Yeah. Has that changed? Does India provide a similar standard, if not better, cancer treatment, and how did this happen?
I can tell you categorically, because I was in US for 28 years, practiced, and I trained in MD Anderson. Today, in India, we have dedicated cancer centers which can provide the same, actually better treatment, because we are more personalized. And with that, I think we are getting better outcome than best of centers. We have done studies on that. We are very big in data collection. And we have published it. Even Harvard Business School has published, where breast cancer outcome is equal or better than best of centers. So I can tell with pride that categorically, the way we do our patient care, research, academics, data collection, which was lacking in India for a long time. As we know, we are lacking in research. Where we are leapfrogging today using technology, we are becoming leaders. And the West is so actually worried about it, in a way, because we can compete now. We have the intellectual mind, and we have IQ. A lot of Indian doctors are leading centers in US, as you know, not only doctors, but, software companies, big companies like IBM, Microsoft, Google, all. We have the intellectual capacity. What was really choking us, certain things were not happening in India, which was preventing us, like maybe infrastructure, cost. This perception of cost is what was killing us. See, India is different countries, as you know. We have 350 million Indians who are middle class, moving up the ladder, demanding the highest care of healthcare possible. 350 million, maybe only 25-30%, but it is equal to United States population. It is equal to Europe. Huge population demanding highest, and we are providing today. But somewhere along the line, we get caught in this cost business, because we are nowhere in the world we provide the type of treatment at this low cost. The people come from Africa, Middle East because of the cost difference. And we have the same technology. How can you take a PET scan and do for $300? Whereas I know recently one of my friends got a PET scan in US for $3,000. 300 to same equipment. So we don't pat ourselves on the back as doctors or others, because the media, the political thing always says the cost is too high. Cost, because there is 900 million population who require help. There is no doubt. But who is the responsibility it is? We say let the government be a monitoring agency. Let them give us challenge and say, look, I will pay what is required, but make sure they get the good outcome. We can do it. But problem is bureaucracy, certain political consideration prevent this from happening. We all are fighting for universal healthcare, as you know. When universal healthcare is doable, we have proposed, if that can be done, India will be one of the best countries in healthcare in the world. I can tell you that because we have all the infrastructure, we have entrepreneurs, innovators, we can, and we are great in pharma. We are good. Even though we don't make new drugs, we copycat drugs very well, So we have produced at low cost. So all of that we have the means. But, certain things are coming in the way. But what we have shown in HCG, where we have gone to tier 2, tier 3 cities, imagine going to Ranchi, Cuttack, putting in linear accelerator, Rangol, so Chumaga, and we showed to the world what everybody thought we can't do. We showed. And once we showed, others are following, which is very good. So it means the linear accelerators are completely replacing cobalt now. High-end quality care, outcomes are getting better. Fear of cancer is becoming less, because people know you can live with cancer. It is a chronic disease. It's only chronic disease which can be cured by them. It's only chronic disease which can be cured. So when you look at it like that, and we stop using languages like terminal care, cancer victim, palliative care, we do right treatment. Like diabetologists don't say, I'm giving you palliative care. Do they say that? Nobody says that. Why in cancer we are using? So these kind of terminologies, lingos should stop. And as oncologists, we should start using the right word and give the right staging to the people. They explain to them. For example, stage 4. If you tell I'm a stage 4, people will think they're gone. Not so. If a stage 4, there are different stage 4. If cancer has gone to the bone, breast cancer, they can live for 10 years, even lung cancer. But if it has gone to the brain, liver, everywhere, maybe a year. So there are different types. What does the patient know about it? So we have to communicate properly. This is where you are proper communication, proper technology, using genomics, everything else. I think it will change. And we all follow the Western standards. Indian genomics, nobody has done. So we are started doing. We have done 10,000 patients. 38% of the time, the genomics is different. They're never seen in other Caucasians. So why are we treating the same way? So this mystery of cancer is being unraveled in our country. And with this, I think we are definitely in the forefront of achieving our goals of bringing in, we're already there. We can even improve on the type of quality outcome, not just for the 350 million, but for the entire population. We can do.
It's super, the way you explained it. So, but I'm going to take a cue from what your last answer. You used two words. One is affordability and second is government. So, when you're running an institution, you need land, you need equipment, you need diagnostics. and you need people, and so all of this costs a lot of money. So when you're talking of providing quality access to healthcare, to access to quality healthcare, it costs a lot of money. What do you think that the policymakers in this country, along with the private institutions, need to do to make not just cancer care accessible, but affordable too?
See, it's a very good question. Let me answer this in a way. HCG, I experimented with HCG by not taking 1 rupee from the government, not 1 inch of land from the government. People said, why don't you write? You're doing great job. Government can. I said, no, I don't want anything. Now, HCG today is a listed company, viable. But the important point to remember is we have penetrated tier 2, tier 3 cities where we have made all the centers viable. Imagine going to Angol, Ranchi, anywhere, and Nasik. Even 60-70% of our patients may be in government schemes. Maybe whatever we do. So we have come to a decision that it is possible only if government kind of understands this and brings in the universal healthcare. Now, another point I want to talk to you today. I did this at Harvard Business School. Now, what is the difference between for-profit and not-for-profit? Not-for-profit also charges. Not-for-profit also has to pay doctors and nurses, everybody. Only difference always been for-profit will distribute the profits when you make to the investors. HCG has never done that. We have never distributed any yields, any dividends. We create value for investors, but the most important thing is when private equity or companies invest with HCG, they are actually contributing to good cancer care in this country. It's an impact factor. They may not understand that, but because we are not giving dividends, we are using the funds, whatever we make, to bring in better technology, penetrate tier 2, 3 cities. This is the model which can be taken by government and everyone. How did HCG do? How did these two? Can we create such models across where government involvement is less? Government can be only monitoring. But government is not like that. I will also do. Because it is not possible. Government cannot be monitoring and also running cancer institutes or any healthcare institutes. It is high time government thinks of what should be the role of government. I am here telling there is a patient who is below poverty. Please give him the best of treatment. I will monitor that. You go and do the treatment. And this is what you put the technology. I want a good return, good outcome for this patient. That is where the government role. But government, because of certain vested interests, other things, politically, whatever, government wants to run institutions. They want to monitor and it's not possible. So this is a point we have made repeatedly, but unfortunately, the people are not willing to listen. All these people, you take Niti Aayog, all these people, we call them for meetings, we ask them to come and talk and all, nothing happens. It is 76% of healthcare in India is done by private. We have penetrated small hospitals. Imagine nursing homes, all of that in small cities. They are the ones who have given healthcare to India. Instead of being pride, we put them down. It is not so. Yes, there are issues. There are some people who are not ethical. There are some who might have done certain things to squeeze profits. But there are always like that. Which system doesn't have? But we can eradicate that, provided you make transparency. Now, today with technology, we can make everything transparent. We are already there. So I think a time has come for this kind of paradigm shift to happen, and it is happening. Whether anybody likes or not, HCG has shown without any government help, we are servicing people. The amount of free care we give is unbelievable, but we don't talk about it. No patient is refused treatment in HCG. No patient is refused. We know how to manage. If somebody wants to have a cyber knife, which normally costs 4 lakhs, a child or somebody with brain tumor come at 11 o'clock in the night, take a free care and go. Why not? That is our model. And that is how I think cancer has to be treated. Only don't compromise because they can't afford. Make sure you do the right treatment, or don't even do. Once you take on, do the right treatment.
I think that's a very powerful statement. Do the right thing. If you have that intent in your mind, your actions will follow. So I think that's a very beautiful thing. So how many patients does HCG manage? How many cancer patients does HCG manage every year? And how many of these actually come from overseas?
Yeah. We manage about 120,000 new patients a year.
Wow.
It is one of the largest globally in the network. And one of the things I want to say, there is no network like HCG. See, there are clinics, there are outpatient, but we have comprehensive cancer centers across India, 23 cancer centers across and one in Nairobi. Number of international patients is about 5%. And it is growing, it is increasing, mostly from Africa. But if you look at centers of excellence in Bangalore, it is almost 20%.
Got it. But did the pandemic, when the lockdown was there, how did it impact HCG? Because I'm sure the outstation, the overseas patients would have dropped considerably. Has it gone back to pre-pandemic levels?
Yeah. Our during the COVID time, you are absolutely right. We almost patients become near zero as because of the lockdown and all. But we have gone now beyond pre-COVID. Things have improved. And there may be a reason. Now people are more concerned about healthcare. They are paying more attention to healthcare. COVID has given them a little bit insight. And even in India, we are seeing the number of people seeking help at dedicated centers of excellence. And from abroad, the number of people seeking help in India has increased. We are back to pre-COVID and actually better than that at this point. And we are also making it, because our Nairobi center is a cancer center, we are also making efforts to make sure patients don't have to come. I don't like this medical tourism word, honestly. I want to make sure it's a destination. They come, they take treatment and go back, and we can continue the treatment there in their own country. Because they need to be, in their own country, particularly with a disease like cancer. We can't then ask them to stay here for months together. So my philosophy has always been, take the treatment to their beds, to their homeland, and do it. That is why we started Nairobi. We want to expand further as we go in the future.
So I wanted to wear a doctor's hat now for the next question. Cancer as a word, the moment you tell somebody that, we have detected cancer, they get scared. So they're very fearful, because the one thing that people have believed is that cancer, there is no cure. And, you are now going to be dead, if not now, in some time, So this fear has been at the back of the mind. And has the technological advancement happened in this space that makes cancer a better managed disease, so that people can live longer and healthier for whatever time they have? What is your view on this?
You are absolutely right. My whole experience in cancer in the 45 years has been to change this perception. Because cancer word has been used not only for cancer. If there is corruption in the society, we hear people using that is cancer of the society. So cancer has been used in a very demeaning way. So the perception people get is cancer means I'm gone. But the reality actually nowadays is different. Because I will explain to you why it is, but because 67 to 68% of the people with cancer today die of other causes, not of cancer. So it's very important to remember, cancer today is a chronic disease and is a lifestyle disease. Now, technology, not only technology, but the most important thing is the knowledge. The knowledge about cancer has significantly changed our perception of how to manage. Along with the knowledge, precision medicine, what we call as, and the reason cancer occurs, the reason some in cancer occurs, why they don't respond to treatment is now being answered through genomics and molecular diagnostics. And we are leaders in that today because we believe that genomic-driven treatment is the future. For example, nearly 50% of treatment we give by traditional way don't work. 50% of the people are getting unnecessarily. We don't know who, because we used to do randomized trials. oh, we use this drug, 50% responded, let us give, 30% responded. What about the other 70? That is why cancer got a bad name. But now, precision medicine, I can do genomics. I can analyze which patient will respond to what drug. And we are now talking about targeted treatment. We are now talking about radio surgery. We are talking about robotic surgery. We used to do big surgeries, remove organs like breast, remove organs like colon. Nowadays, we hardly do any mastectomy. We hardly do any laryngectomy. So organ preservation, quality of life, no need for any hospice care. Can I manage pain by treating the exact cause where the pain is coming from? These are added to what we call as quality of life. That is why HCG has a logo, adding life to years. We add life to years. With that kind of quality, people are living longer with less pain, no suffering. So, big COPE group, because they have become advocates, talking about how they are living. So, it is undergoing a big change. So that is why, today HCG sees 120,000 cancer patients who seek HCG and come. I want to go to dedicated because they don't have fear. They know once they come in there, they get the right treatment. That is why going back, right treatment first time will dissipate this misconception. If you don't do, cancer is unforgiving. When it comes back, that is why you get a bad name, because you're not planned and treated. That is one last word I want to say. Cancer cannot be given by 15-minute prescription. It requires multidisciplinary clinic, experts together, and we have to analyze and say what is the right treatment can be given at that point. This is the big change in cancer care.
Right. Dr. Ajaikumar, my last question to you before I let you go. I know you have to rush for a meeting, but my last question to you is, you mentioned that, there are demographic that play a role. Does not mean that we treat Indian patients the same way as we would treat the Western world. And so are certain races or demographic populations that are more prone to certain cancers than the others? And second is, what will be the role of genomics, not only just to find this out, but to make cancer care better in the future?
Yeah, race definitely, there is associated, but this is just a Pandora's box we are just opening, because all the trials in the past has been done based on Caucasians. So when you look at Indian population, why do we see no more head and neck cancer? Even cervix cancer, it may be related to human papilloma virus, but is it more in Indian population? Why is certain esophageal cancer more? And why prostate cancer is more in African population? It's very high in African population. So these are some of the myths we don't know. We are working on that. The answer lies in your second question, genomics. See, as we study more population-based genomics, we will identify certain genes which are today called not actionable, but they are actionable. As we identify these genes, in head and neck, we have identified 38 genes which have never been reported in Indian population. So as we do this journey, collect more and more data, we are going to find out for each type of cancer, each individual, there is a reason. Because inflammation is the cause for cancer. Obesity, inflammation, whatever, it is the cause of cancer. So what inflammation triggers these genes to undergo mutation and cause cancer is the myth, is the enigma. As we open that in Pandora's box, I think we will have answers in terms of drugs, which drug we are already seeing, which drugs will work for what targeted therapy. And we will have answers to prevent cancer, where, for example, DNA editing, other things will actually prevent cancer. So ultimately, in my view, every patient with cancer should undergo genomic thing. Actually, overall, their cost will come down because right treatment will be treated the right way. Once they undergo genomics, we should be genomic-driven treatment. This will revolutionize the outcome of cancer patients. This is where we are headed. And since the cost of gene genomics has come down significantly, it is continuing to come down. My target is, can we do it for like $100, some 7,000 rupees, can we do a complete gene sequencing? That is what we are headed for. As the volume increases, the cost will come down. So that is where we are. What used to cost, lakhs of rupees at one time, it was 20 lakhs, 30 lakhs. It's come down to 1 lakh. So 1 lakh, can we take it down to 10,000? That is what we are working on.
That's really wonderful. So what is it that HCG is going to do in the next 2 years, which is going to redefine the industry?
Now we are actually working on making sure that with 120,000 patients, quality is important. We can't compromise. So we are in the consolidation phase, 23 centers, consolidate, focus on quality, outcome, tumor boards. We do tumor boards. We have 450 oncologists. We do tumor boards, focusing on outcomes. My time is now spent on understanding recurrence cancers. Why does a cancer come back in which place it is coming? Mortality review, where it is post-op, what a patient mortality, why it should happen. So I want to bring the standards of quality to a different level, and which doctor should perform what surgery, multidisciplinary clinic. Then we go to expanding further. So the next year, at least, we are focusing on that consolidation. We are doing very good. As you know, the results we published were very good, and we'll continue to give good results. I'm pretty sure on that. But meanwhile, financial results are one, quality results are one. So both of them has to be good in order for us to meet our dream of making sure cancer is treated the right way first time.
Awesome. Dr. Ajaikumar, it has been such a pleasure talking to you. I thoroughly enjoyed this conversation. And I think it is, really nice of you to take out time to be with us.
Oh, it's my pleasure.
Today. Thank you so much, sir.
Thank you.